You know about the paranasal sinus, isn't it? How many paranasal sinuses are there? There are 4 paranasal sinus. One is the frontal, then comes the ethmoid, maxillary and sphenoid, which cannot be palpated, which is posteriorly around the skull base, isn't it? So all except the maxillary sinus are unpaired and maxillary sinus are 2 in number, paired. What are the functions of this paranasal sinus? It was not proven earlier. So we told that the paranasal sinus contribute to the functions of the nose. They reduce the weight of the skull or lighten the skull. They increase the olfactory area and they give resonance to voice. They humidify and give warmth to the inspired air, etc. But now it is proven that these paranasal sinuses contain lots of nitric oxide. Okay, nitric. Nitric oxide. And this nitric oxide has got bacteriostatic and also vasodilating property. How come vasodilation? Because the inhaled air goes through the sinus, it goes to the lungs also and contains a nitric oxide. It causes vasodilatation of the pulmonary vessels. So there is increased oxygen intake. And what about the bacteriostatic action? That is by 2 methods. One antimicrobial action is by 2 methods. One is by a bacteriostatic action and also by increasing the or improving the mucociliary clearance. In the coming classes, I will teach you about the osteology of each bone and also the endoscopic anatomy of each sinus inside the bone. That is, endoscopic anatomy has to be learned thoroughly, and without that we cannot go for a functional endoscopic sinus surgery or any type of endoscopic nasal surgeries. Do you know what is this bone? This is frontal and this is ethmoid. Don't worry. Today we will deal with the frontal bone and also the frontal sinus. And I will tell you about the osteology of the frontal bone, the peculiarities of the and boundaries of the frontal sinus, and frontal recess in detail with special reference to the endoscopic anatomy and also its clinical significance. So just see the osteology of frontal bone and come back. The frontal bone, it forms a forehead. It is a forehead and also the roof of orbit, and frontal bone forms a roof of orbit in an articulated skull. This is an articulated skull. And you can see the individual frontal bone. This is a individual frontal bone again, which forms the roof of orbit and also roof of ethmoid sinus. Okay, and this fovea ethmoidalis of the ethmoid sinus forms individual impressions upon the frontal bone. Okay, this what is shown now is the individual impressions made by the fovea ethmoidalis, and that is called the fovea ethmoidalis ossis frontalis. Fovea ethmoidalis ossis frontalis, which is comparatively thicker than the rest of the bone. Fovea ethmoidalis ossis frontalis. Okay, and above that what you see is the frontal sinus. Now it is the frontal sinus. Okay, and the bone is thinner towards the orbital roof, and that part, that is below the medial end of eyebrow, we look for the frontal sinus tenderness because it is the thinnest part. Okay, below the medial end of eyebrow, corresponding to the floor of the frontal sinus. Right? Now you can see the frontal sinus between the anterior and posterior table of the frontal bone. See, that is the frontal sinus. And remember, in an individual frontal bone, the frontal sinus has no ostium. Only when it is articulated with the ethmoid bone, there is the frontal sinus ostium and also the frontal recess. Otherwise, there is no frontal sinus ostium. And also, this frontal sinus depend upon the ethmoid sinus for a correct drainage of the secretions. And this is a ethmoid bone. Here you can see when it is articulated, right? And the inferior relation is of the frontal bone is the orbit, the ethmoid labyrinth and the nasal cavity. And superiorly comes the anterior cranial fossa, olfactory niche and the olfactory tracts. And medially comes the cribriform plate and the olfactory niche, right? Now we have seen the articulated skull with individual frontal bone and also the frontal sinus. I hope it is clear. And one more thing regarding the frontal sinus is usually asymmetrical, and it has got two walls, that is the anterior wall and the posterior wall. Here also you can see that it has got an anterior wall and a posterior wall. This is a frontal sinus. This is anterior wall and this is a posterior wall, and this anterior wall is diploic and the posterior wall is cancellous. You know the diploic cells contain marrow. So osteomyelitis of the frontal bone affect only the anterior wall which contains marrow. Okay, that is one important thing you have to remember. And also one more thing, the normal shape of the frontal sinus is scallopy. This is the shape. Okay, scallop means the shell. Okay, the word meaning of scallop is shell. So it is normally, this is we call it a scalloping appearance. And the radiologically, if there is absence of scalloping, okay, if there is absence of scalloping with the expansion of the frontal sinus is seen in case of a mucocele of the frontal sinus. Okay, mucocele. So the anterior wall is diploic and the posterior wall is cancellous. So the osteomyelitis affect only the anterior wall, and the normal appearance is called scalloping appearance, and it is absent along with the expansion of the frontal sinus in case of a mucocele. Okay, and this frontal sinus is absent at birth, and it is radiologically visible by age of 4 to 6 years, and it comes to adult size by puberty. Okay, radiologically visible by 4 to 6 years, and by 18 years it becomes adult size or completes its growth, and it is absent at birth. This frontal sinus is a dependent sinus. Okay, why it is dependent? It is dependent upon its drainage on ethmoid. Though this ethmoid, we have seen the ethmoid bone, it is very fragile, very small, but it is the master controller of all the paranasal sinus activity. This ethmoid bone is very important, and all this frontal as well as the maxillary sinus depend upon the ethmoid prechambers. And also during development, this frontal sinus develop by two methods, by two routes. One is by the pneumatization of the frontal recess into the frontal bone, or it can be pneumatization of the anterior ethmoidal cell into the frontal recess. Okay, so it has this frontal recess area. I will tell you about the frontal recess, and before going to that, we can deal with the mucus transport mechanism or the route of mucus transport of the frontal. You can see there is an active inwardly directed transport of the mucosa, first along the interfrontal septum. This one, it goes, from there it goes laterally along the roof, and then it comes again, turns and comes medially by through the floor of the frontal sinus, and also the lower part of the anterior as well as the posterior walls. Okay, so it inward direction, it starts actively, goes laterally, and then again it comes back. So floor of sinus and also the lower part of anterior and the posterior walls, and from there it goes down. So this is the frontal sinus ostium. And when I saw the bone, I told you that in an individual bone, the frontal sinus has no ostium. It has got an ostium only when it is articulated with the ethmoid bone. Okay, so that is the importance of that. And this drainage occurs through the lateral aspect of the frontal ostium. Okay, the discharge comes out of the frontal sinus through the lateral end of the ostium. Okay, and this is one round loop. But all the mucus will not complete by a round loop. Only 20% will come out through single round loop, and the other part will go, again it will go and form a whorl-like pattern. Okay. It will form a whorl-like pattern and again recirculate. Recirculate and then it will come out. Okay, each time it will come out. So that is how. And after that what will happen? This part is called the frontal recess area. That is also very important. And after the frontal ostium, there is an extension of the frontal sinus into the nose. So this extension of the frontal sinus into the nose is called the frontal recess. Okay. And this is very much important for an endoscopic surgeon, this frontal recess area. And what is that? Actually this part is the frontal recess area. This part. Here this is the frontal recess, and here this I have read it as a red color, that is the frontal recess area. Frontal sinus drainage pathway to that of an hourglass. Okay, this area, this part. What is that like? Hourglass. This is an hourglass. So this frontal sinus on one side, then towards the frontal ostium it comes to a constricted part, and again it enlarges towards the nose. See, shape of an hourglass. Okay, and the outward transport of the mucus depending upon the insertion of the uncinate process. What is this uncinate process? That I will tell you when I talk about the ethmoid sinus. Okay, so for the time being, this uncinate process is a crescent or a sickle shaped part with one end always attached to the inferior turbinate. This is nose, this is the inferior turbinate, so one end is always attached to the inferior turbinate, and this is the uncinate process, this part. Okay, so this is the uncinate process. One end is always attached to the inferior turbinate, and superiorly it has got three attachment. Either it can, this is orbit, okay. So from the inferior turbinate, it can go either into the lamina papyracea or the medial wall of the orbit, or it can go to, from there it can go and insert into the middle turbinate, or it will go and insert into the skull base. Okay, so there are three attachments, superior attachment of the uncinate process. Inferiorly it is always attached to the inferior turbinate. Superiorly it can go either to the orbit, either to the medial wall of orbit, or it can go and attach to the, this is the middle turbinate. Okay, this is the middle turbinate, to the middle turbinate, or it can go to the skull base. Okay, so this according to or depending on the upper attachment of the uncinate process, the drainage, route of drainage of the frontal sinus may vary. Okay, that you can see here. If this uncinate process is attached to the lamina papyracea, which is a papery thin bone on the medial wall of orbit. Okay, if it is attached to that, this frontal sinus will drain into the middle meatus. Okay, and if this attachment is to the middle turbinate or to the skull base, what will happen? Here comes the ethmoid infundibulum. Okay, here comes the ethmoid infundibulum. don't get confused about the ethmoid infundibulum and uncinate process. I will detail along with the ethmoid sinus. So if this is attached to the middle turbinate or to the skull base, then this frontal sinus will drain into the ethmoid infundibulum, and after that it will collect the discharge or the drainage from the ethmoid, and along with that it will also, this is a maxillary sinus, and from the ethmoid and also from the maxillary this will go into the nose, and through the mucociliary action it will go to the nasopharynx, and from there we will swallow. Okay, so that is how the drainage of frontal sinus happens. Here it is in a word-like fashion. It comes out through to the frontal recess, and depending on the attachment of the uncinate process, it will directly go to the middle turbinate, middle meatus, or it will go to the ethmoid infundibulum, and after that, along with the discharge or the drainage from the ethmoid and maxillary, it will go to the nose, and from there to the nasopharynx, and then it gets swallowed. So that is regarding the drainage of the frontal sinus. So the anatomy, knowledge of the anatomy of the frontal recess is the topmost important before going for an endoscopic approach of the frontal sinus. And also the radiological anatomy you must be very thorough with. So this is the frontal sinus, this part, and then it comes and get a constricted part, that is the narrowest part is the frontal ostium, and again it expands to a frontal recess which is situated in the ethmoid bone. Okay, this is the frontal recess. So altogether it forms an hourglass shaped structure, and the most constricted part is the frontal ostium. Okay, and this drainage of the sinus depends upon the location or the attachment of the uncinate process, and also the presence of ethmoid bulla. If the bulla is very much enlarged, and this will anteriorly push the frontal recess. Okay, so that means this size and shape of the frontal recess is depend upon the ethmoid prechambers. Okay, and this is the sagittal orientation of the frontal recess. And you must remember that if you want to go for a frontal sinus or any endoscopic sinus surgeries, axial, coronal as well as the sagittal cuts of the CT scan is very much important. Coming to the limits of the frontal recess. And what is this? Actually, this is the agar nasal. Again, about the agar nasal cell, I will explain along with the ethmoid. For the time being, just remember, it is an anterior group of ethmoid cell which is pneumatized. So this is the agar nasal. Here, this is the agar nasal, and this is the frontal recess. So anteriorly, what are the limit of the frontal recess? Anteriorly comes this is the frontal beak. Okay, this part. What is that? That is the frontal beak. Okay, so anteriorly the frontal beak and the agar nasal, and the posterior limit, what is this? This is the ethmoid bulla, right? And this is the skull base. Okay, so posterior limit is by the bulla ethmoidalis and the skull base. And what is the lateral limit? Lateral comes the medial wall of orbit and also the lacrimal bone. Okay, and what is the medial limit? This is a middle turbinate, so the vertical plate of middle turbinate comes the medial plate. So here comes, this is the frontal recess. You don't forget the limits. I will explain once more. Anteriorly the frontal beak and the agar nasal. Posterior limit is by the bulla as well as the skull base, and laterally this is the orbit. So the medial wall of orbit along with the lacrimal bone forms the lateral limit, and the vertical plate of middle turbinate forms the medial limit. So that is regarding the frontal recess, and this identification of frontal recess is very important while doing endoscopic sinus surgery of the frontal sinus. And working at the frontal recess area, we always prefer a 30-degree endoscope. And the instrument used is blakesley-weil instruments. Okay. So blakesley-weil instruments has got a fenestrated jaws. So we can see while catching the area, we can see the structures behind that. That is the importance of this blakesley forceps. So blakesley-weil instruments as well as 30-degree endoscope is used to work near the frontal recess area. Okay. And usually what is the entry point to the frontal recess? This is the middle turbinate. So on reaching the middle turbinate, just below the axilla of the middle turbinate, this is the axilla comes here. So just below, we always put the instrument andro-superiorly. Okay, so this will be the direction, andro-superiorly. Remember that this one, andro-superior. So the instrument is directed andro-superiorly from the axilla or just below the insertion of the middle turbinate. And always use 30-degree endoscope and also the blakesley-weil instruments. If there is any difficulty on identification of the frontal recess, what will you do? There are so many techniques. I will tell you some of them, very secret. I will tell you only to you. One is ask the patient to raise the chin. The idea is to extend the neck. That is, we get it by patient is in supine position. So ask the patient to raise. If the patient is under GA, just raise the chin of the patient. So that a very good visualization of the frontal recess area will be got. Okay, that is one thing. And then, even then, there is difficulty in identification, especially in case of repeated surgeries, recurrence of the disease, or there is extensive scarring, or there is one thing. Usually we keep the middle turbinate for all surgeries as a landmark. But if there is revision surgery, in many of the cases, this middle turbinate will be lost. Sometimes the previous surgeon may remove or accidentally or purposefully remove the middle turbinate. In that cases, there won't be any landmarks available. For your information, as far as possible, always try to retain at least a part of the middle turbinate. That is very important for future surgeries. And if it is not there, then how will you identify the frontal recess? That is the method number 2. That is by doing a Beck's procedure. That is, what is that Beck? Beck's procedure is frontal trephination. Okay, that you will towards the floor of the sinus, towards the floor you put an incision, retract it and through the floor, by drilling the floor of the frontal sinus, reach the inside the frontal sinus, or introduce a endoscope. Introduce an endoscope through this. While doing that, you put the tip of the blakesley forceps through the frontal recess in the nose. Okay, so your endoscope is in the frontal sinus, and intranasally you introduce a blakesley instrument at the proposed site of the frontal recess, and then you try to project it. So through the sinus you can see the tip of your instrument projecting into the floor of the frontal sinus, and if it is verified by this endoscope already in the frontal sinus, you can very well puncture that site. That is the second method. And the third method, you keep your 30-degree endoscope at the proposed site and look from outside. The surgeon look from outside. If it is inside the frontal recess, the transillumination of the frontal sinus can be beautifully seen. Okay, so one is at the axilla of the middle turbinate, poke the instrument andro-superiorly and the second one by doing a Beck's procedure or frontal refination and poking the blakesley instrument intranasally at the proposed frontal recess and looking for the projection inside the floor of the frontal sinus, and third, looking for the transillumination. There are different type of frontal cells, and there are so many classifications of the frontal sinus cells, and the most widely accepted one is a Bent and Kuhn classification, and then this depend upon the Agar-Nesse cell. I already told it is one of the pneumatized antidiathmoidal cell, and this is the Agar-Nesse. This one is Agar-Nesse. So this bent type 1 frontal cell is only one cell above the Agar-Nesse. Okay, one cell above the Agar-Nesse is type 1, and if there is more than two or more cells above the Agar-Nesse, you can see only one, it is type 1, two or more, it is type 2, and a large cell extending into the frontal sinus, and that is above the Agar-Nesse. This is type 3. Okay, so a single cell above the Agar-Nesse is type 1, two or more above the Agar-Nesse is type 2, a large cell extending into the frontal sinus above the Agar-Nesse is type 3, and a large isolated cell in the frontal sinus. Can be like this, or it can go like this, or it can be anywhere. This is type 4, a large isolated cell within the frontal sinus. Okay, if in the sagittal section you will see like this, a type 4. So that is the Bent and Kuhn classification. There are type 1, type 2, type 3 and type 4. Earlier I told you that the CT scan of the nose and paranasal sinus, that is in the axial, coronal and sagittal views, are very important or mandatory before you decide or plan an endoscopic sinus surgery. And in the sagittal plane you can get the antero-posterior distance. Okay. And in the coronal cut, this will be the coronal cut. In the coronal cut you get the mediolateral. So mediolateral, this is from the medial to the lateral extent you get from coronal, and anterior and posterior you will get from the sagittal. And from the frontal beak up to the bulla, if this antero-posterior diameter is more, the frontal sinus dissection will be easy. That is also important. Okay, this length has to be calculated. And coming to the clinical significance or surgeries, I will describe in detail along with the surgeries of the frontal sinus. But for the time being, just remember, there are external surgeries and also endoscopic sinus surgery. The external surgery is mainly the external frontoethmoidectomy. Okay, Lynch-Howard. Lynch-Howard operations, that is the external frontoethmoidectomy, and the medial limb of the Lynch-Howard incision can be extended laterally depending upon the extent of the disease. That is external. And internal, mainly it is draft procedure. There are 4 types, that is the draft 1, 2A, 2B and 3 or modified Lothog procedure. Okay. So regarding the frontal sinus, we discussed about the osteology of the frontal bone and also the individual frontal bone with the frontal sinus. We saw the drainage pathway, mainly the pattern of the drainage and also the frontal recess, which is an hourglass shaped area from frontal sinus, frontal ostium, and again in the ethmoid sinus as a frontal recess. Then the limits or the boundaries of the frontal recess and the method to identify the frontal recess, and also the type of frontal sinus cells according to the Bench classification, and also the surgeries. Mainly we talked about the external procedure and internal endoscopic or draft procedure. And for completion's sake, a word about the arterial supply, that is mainly from the supraorbital, and partly a minimal amount is from the supratrochlear blood vessel, and the lymphatic supply is into the upper deep cervical either directly or through lateral retropharyngeal lymph nodes, and the nerve supply is from supratrochlear and supraorbital branches, which are the ophthalmic branches of ophthalmic division of trigeminal. Okay, if you have got any doubt, just ask me in the comment box. Thank you.